Thank you for staying with us through the afternoon. I am, so in that marathon analogy, still completely buzzed, still excited. I absolutely, I thoroughly enjoy every individual and the companies that are on this panel. And so the opportunity to get to share them with you is exciting for me because they're doing some amazing work and are CEOs who are thriving. And that's not in a state of a disassociated reality from what is occurring in this ecosystem, the challenges of businesses that are at Convergence. And we're going to talk about those, similar to what we did in the investor panel as well. The challenges and the opportunities in this ecosystem. But each and every one of them are doing exciting work and are spending time in areas where they are companies who are meeting their market. So with no further ado, because all of you have heard enough from me as well, Grady, why don't you kick us off? Tell us a little bit about you and your company and kind of that inflection point of convergence.
Sure. Hi, my name is Grady Hanna. I'm CEO of Night-Ware. We've developed a digital therapeutic that runs on the Apple Watch that treats nightmare disorder, most common comorbid with PTSD. It's a software application that utilizes sensors on the watch to monitor a person's sleep. And using machine learning, we create a profile of their sleep. And when we detect a nightmare, we intervene by buzzing the watch to arouse them out of the nightmare without waking them. We're in a clinical trial at the Minneapolis and St. Cloud VAs. And we're in pre-submission with the FDA as a regulated medical device to be reimbursed through the VA and other payer networks. I grew up in St. Paul and spent 15 years out in Silicon Valley. And when I came back, we had a daughter, and when I came back, I wanted to really embrace healthcare and the device history of Minnesota. And as we all know, or many of us know, for many years, Minnesota was the center of supercomputing for the world as well. Many of the inventions that run the New York Stock Exchange, for instance, were all invented in Minnesota and Eau Claire, Wisconsin by Seymour Cray. And so there's so much innovation here, and people here are just problem solvers. And so when I learned about Night-Ware and got involved, I really haven't looked back and have been able to access the great networks here in Minnesota, including Medical Alley.
Hi, my name is Liwanag Ojala, and I am very proud to be the CEO of CaringBridge. CaringBridge is the social network for health journeys. And I'm channeling Ryan, who says that we should have a little bit more Minnesota moxie. We were born in Minnesota 21 years ago, and we continue to thrive here in the Twin Cities market. And what we really do at the highest level is we make sure that patients, caregivers, and their communities are not alone. And I have been listening for the last few days about the importance of making sure people have the social support that they need. And we've been doing that in healthcare and technology for 21 years.
That's awesome. Hi, I'm Paul Owen. I am the CEO, and proud to say I am the CEO of OneOme. OneOme is a company that was co-founded with Mayo Clinic and a small healthcare IT incubator in Minneapolis, Minnesota in 2014. Simply, we are considered a healthcare technology and diagnostic company together. We are specifically focused on medication optimization management at this moment in time, and look forward to growing in other areas of genomics as well. From a convergence perspective, it's all over. I mean, there's a tremendous amount of convergence going on in our space, from the payers at the highest level who know genomics and personalized medicine is coming and is here, and they have to prepare for it, but they're not 100% sure how. So it's an exciting time to be able to partner with them. Second group that I think is very much under pressure and under convergence is the health systems themselves, with all of the different initiatives. There's not a health system in the country, or frankly across the world, that doesn't have some kind of a chief innovation officer. They're being asked to cut, reduce prices, cost pressures, but at the same time innovate and get ahead of this genomic wave that is happening. And then consumerism. Just recently, the Deutsche Bank put out a report on DNA consumerism. I don't know if you had a chance to read that. You know, they're looking at a huge, huge market specifically for consumerism in healthcare to DNA. And so that is happening all at the same time, and if you wrap around the technology and the accessibility of information of that information. And then lastly, somebody spoke about it at an earlier panel about driving down the cost. You can get a whole exome for $40 now, compared to just a few years ago it was $4,000, and then a few years before that it was $40,000. So it's an exciting time.
My name is Amanda Tufano. I'm the CEO of Genevive. We're formerly Geriatric Services in Minnesota. We're a medical practice care management organization, and so I kind of looked over the list. I think I'm one of the only medical practices here. I think that's a huge opportunity, and Jodi's given us a great platform to talk more about what that means for the medical practice, because we really view ourselves as the problem and the solution. And so how do we really address that head on? We care for about 5,500 average daily census patients only in Minnesota right now. We go up to St. Cloud, down to Northfield Faribault, over to Buffalo, Aiken, almost to Wisconsin. So a nice spread. We're in 70 nursing homes. We're in about 30 TCU or rehab centers, and we have a home visit program where physicians and nurses go into people's home. And so we're a virtual clinic. Our kind of claim to fame, we've been around for 15 years, and we built our platform on value risk contracting. So 90% of our revenues in value risk contracting, specifically with the duals in the state of Minnesota. So that's MSHO, Medicare, Medicaid, and so I'm going to talk a little bit more about the interesting parts about Medicare, hopefully today. That'll kind of be teased out, but we've been solely in that DSNP value-driven company in the medical practice, and so it's been really exciting, and I think it's going to be an interesting conversation today on convergence and what that means for how a medical practice can think in new ways.
So similar to our format earlier, I'm going to at least ask an individual question of each of the panels so you can get a sense, but I think one of the pieces that we were most proud of in our prep is one, you've got Minnesota-based companies, really fulfilling that medical alley vision of elevating the presence and the conversation. If you've spent this morning or you were here yesterday as well, you are at the intersection of a software as a device, a social isolation solution company, personalized medicine personified, and the ability to take care of our most vulnerable and those that have the highest need represented here in one panel, really at the Convergence is some very, very interesting. So, Liwanag, I'm going to start with you in that you're a 21-year-old company meeting your market. I mean, it is. You could not have had more of a commercial for the value proposition of CaringBridge. I think the social isolation, the stat of the prevalence of disease and implication coming out of social isolation is really coming, and that's something that you've lived, hearing the CaringBridge stories brought to you. So talk to us a little bit about the tailwinds that CaringBridge is really meeting a market right now. Talk to us a little bit about the opportunity in front of CaringBridge.
Well, a lot of the problems, many references in the last 2 days about isolation, how it's really important to make sure people are not alone, what's the impact of isolation on health outcomes. And we've really been doing the same thing for 21 years in unique ways as we've moved where consumers have migrated the way they want to share their stories and the way they want to connect with their communities. So it's more about us being consumer-centric over the last 20 years. It used to be a conduit for communication only, and what we've discovered in our pathway to better understand healing is what does that really mean, and how do we measure the results of all of these, for the marketing folks in the room, user-generated content over 21 years that has not had a medical intervention. How do we understand that data, and how do we then inform what priorities we want to pursue in order to better serve people in this quest to make sure that they're connected with others? So at the heart of it, we've been really the same thing, and I will say that we've only been about health, which is also a unique value proposition for a social network. Many people are very surprised when I share some of the statistics about our market reach. I always dream that I'll get to go back to the healthcare venture capital world where I can do the 9 to 11 slide pitch. But I will tell you, 27 million unique visitors visit a CaringBridge site every year. We are operating a social network on about $9 million, and we have all the passion in the world to continue to do this, not in an ad-based revenue model. And so I'm very grateful to be invited to Manova because the only references that we really had about nonprofits in this conference have been about the difference between nonprofit leaders and business people. And I will tell you that if you want to find entrepreneurs and we want to be in a world of convergence, then think about the executive directors in the world who are working with the restraints that they have. By the way, they also know how to raise money. And they are doing things that are really the kind of impact that we want to create in the healthcare system. So I threw a lot at you there.
No, but you bring up the convergence that's coming at the social networking, moving from your founder using a web and a static platform that was for communication. You're now mobile, which has also presented its fair amount of challenges in a tech perspective. So the tech development efforts that you've been under, moving from a nonprofit communication to a mobile health platform, really going after social isolation, mobilizing communities. You've had to deal with the Facebook effect. You and I talked about that on one of the prep calls, right? That
Yes.
Just that concern. So,
well, we are not an ad-based revenue model. We don't sell data. We honor our privacy policy, which gives complete control to authors on how much they want to share and when and in what ways. And so we've not had to really make many adjustments regarding that business model. 90% of our revenue comes from individual people who use the service. And last we counted, which was last February, we've had 2.1 billion visits to a CaringBridge site. And our lifetime visits are 750,000 sites, which, by the way, we've never retired. So if you used the service 21 years ago and you want to go back to a site, you have the ability to go back and memorialize or celebrate a health journey. So we haven't really had to make many adjustments because we've always been ahead of that. And through the generosity of our donors, we've been able to keep that model. And what's great about that is we don't have to make the compromises. And fortunately, hopefully, I'll never be in front of Congress at a hearing, which won't happen because we don't sell ads and we're not going to do some of those things. But it also means that we can't compromise on how users want to use our service. So we have some of the same challenges that every other technology company here at Manova have, which is, technology capability building is very expensive, and we have to have the right talent, and we have to be ready to continue to scale, because as impressive as those numbers are, the clinicians in the room know that if you just look at a single diagnosis, single health state, the number of people diagnosed with that today is just an astounding number. So there's lots of opportunities for us to continue to serve more and more people in the future.
yeah, one of the pieces I've been impressed with is the untold stories, the little vignettes that have occurred in the videos, ebbing and flowing during the context. And I think there's an interesting component here of the PTSD, the social isolation, the genomics to empower, the personalization of medicine for more efficacy, and then the untouchables. I mean, there's an interesting theme throughout this, and we've picked on a number of them in our prep, but Amanda, you sit at the intersection of some of the sickest of the sickest in our communities. You all have been at this for a very, very long time, and you're making money under value. I mean, the longevity, the fact that you are in a value system that is now kind of the du jour of a reimbursement program, and the longitudinal aspect that you're dealing with, at some level, folks have viewed as kind of the untouchables, the people that the system didn't think could be helped. So talk about that. Talk about that you are, again, a company meeting your market at this point of convergence in reimbursement programs, and a lot of people who are very, very focused on your market.
Yeah, I mean, there are a couple pieces in there to kind of highlight. One is just the rise of Medicare. And so I'll spend just a minute of how Medicare is a little bit different here. And I won't spend any time on the silver tsunami, right? It's coming, they're aging. The fastest aging population right now is the 85 plus. And that's really where we specialized. We really specialize in kind of the 5 to 3% spending 50% of costs in the market. And so, I also think that we're really well set up for what the future of Medicare looks like. But Medicare in Minnesota is so strange. The sunsetting of these cost products is kind of bringing in all of this new Medicare Advantage work, but with that is coming all these new challenges. So while we haven't really ever embraced Medicare Advantage and what that looks like and that huge opportunity, we have been leaders in the nation around the duals. We really are known for, and have since the early 90s, really led the dual space, understand Medicare, Medicaid, the intersection, and what are the programs that make that really successful. And I think in our future world, we are seeing the rise of Medicare Advantage and the payers taking risk, and then who's going to be a payer, and I think that can be turned upside down. I think Alina Aetna's proving that anybody can kind of start one and see where we go with this. We're seeing increased competition in the duals, partly because of the HMO rule, going away in February of last year. Other HMOs are now going to be entering the market, and so we have this rise of for-profit healthcare. Specifically, they're actually going to get into government programs. The duals are coming up, and we have other special need programs. And so Part C of Medicare gives us a bevy of options for new things that we haven't done. One is the institutional special needs program, or the Medica had a long time chronic condition, special needs program. So as we look at all these different opportunities, it's going to be really fascinating at what we kind of do with that. And what we have kind of said is, our value proposition is we take care of patients that are high cost, and we're very blessed in that, doing the right thing in geriatrics often improves quality and saves money. And so how do we leverage 15 years of value proposition of value contracts and the right business infrastructure in the right clinical work, the right, accessible, ethical clinical work with this changing market that's swirling around us?
But that took a culture really being foundationally built on having the fortitude. I've sat with you and Dr. Nick.
Yeah.
I know that you have talked about, I joke about having bark marks on my forehead at times from, pushing up against one tree in the forest. You all had to have some intestinal fortitude and culture that really could see that vision to get to value. Talk about just the history and kind of the formation, and then your vision about where Genevive is going.
Yeah. So I'm going to back up just one time. So to answer that, I think it also has to be, at least set in the context of, when the millennials were in middle school, everybody started throwing this word around, or the metaphor of a foot in each, 2 feet, right? A foot in a dog, a foot on the boat, it's getting away from us, what are we going to do? The rise of the ACOs, and we saw this year the market step away from the ACOs, and what does that mean? Because I think they really answered that. Health systems can be very successful. That foot in the boat that's quickly getting away from you is government products. And it can be really small, and it can be really niche, and then what does that mean? And for us, what we have seen, and we're a joint venture today with one of the largest health systems in the state, is an intentional space carved out in a separate area outside of bureaucracy, outside of some of the tape, outside of some of those things, and put that innovation in a small, nimble place and allow us to flourish outside of that, because there's not enough government programs in the Alina or the Fairview systems to really push change. It is, but it also isn't, because they're still running their hospital system. So if you subset that and you put that in a new space, there's a lot of power in that. And so we built the company on this business infrastructure 15 years ago of 100 patients in the DSNP taking full risk on those patients, taking full financial risk on those patients. And now we're about 3,500 patients just in that space alone. And so that journey is okay to answer that value is not for everyone, and sometimes that value is for a certain subset of groups. And then how do we allow and create a company that can have new innovation and fast innovation and scalable innovation?
Yeah.
Does that kind of answer that?
Absolutely. And so speaking to subsets of populations, right? Grady, you spoke to making a very, very conscious choice to build a company here. And obviously with your Silicon Valley background, the lore is that, that's where innovation, that's where companies are built. Not only did you make a decision here, but you're in category creating of software as a device. You sat at the convergence of multiple opportunities, really leveraging an Apple Watch platform. Talk a little bit about the advantages of being here, and then the category creating of software as a device. Not a lot of people are familiar with that within kind of FDA rules as well.
Right. There has been an enormous amount of regulatory process and progress around software as a device. Multiple rulings have come out in the last 12 months approving products as both de novo and 510K designations. And that's really key for reimbursement, right? So that sets the stage. And in terms of my education, right, coming from the Valley, regulation was anathema, right? It was absolutely something to stay away from. But now, as I've been educated on it, and my chief marketing officer, she really educated me as to the benefits and the requirements. And from a financial standpoint, people with PTSD tend to not have a lot of money to be able to purchase an Apple Watch and purchase a phone and purchase a subscription. But beyond that, they are getting, there is a strong concentration of care for PTSD within the VA, within Medicaid. And so there were opportunities to improve on care, because I think we can all just say from a topical perspective, right, PTSD is up there with the opiate crisis, where people see that these veterans, they've given themselves and they're killing themselves, right? They've given of themselves for all of our benefit and they're killing themselves. And what are we gonna do about it? And so, and then in terms of, we're not a silver bullet, but people with nightmare disorder, comorbid with PTSD, and that estimate is about 70 to 90% of people with PTSD have nightmare disorder. Independent of any variable, if you have nightmare disorder, you're 5 times more likely to exhibit suicidal behavior. And so if we can solve that problem, because these psychiatrists, they're able to see people for 30 minutes in a lot of cases, right? And whether or not they'd want to be able to do psychotherapy for these people over time, they don't have the time. There's a supply problem. And so if we can give somebody the ability to get a hold of their sleep, because from talking to multiple practitioners, both psychologists and psychiatrists, they're really left treating symptoms of anxiety and depression. They have no insight into a person's sleep. Sleep studies don't bring these things to bear. And so it's really phenomenological, right? How are you feeling? What are you experiencing? What behavior are you exhibiting that I can observe in the short period of time we have? Well, if now we can provide continuous monitoring, if we can provide an intervention that gets people sleeping, and if you allow me just one moment, we're working with a pilot group up in Rhinelander, Wisconsin, and there was somebody on suicide watch, and the gentleman we're working with is a certified peer specialist, 22 years in combat in the Marines. He immediately put a watch on this person, and this is not a medical claim, let me qualify, but within 2 days, his risk of suicide was able to be significantly downgraded after 2 days of wearing an Apple Watch. So if this can be this simple with this type of profile with so few side effects, so little risk, why not go as fast as we can to help these people and then work backwards to figure out where exactly we fit in.
And you are very vocal not only on just the life-saving. Really, we had that conversation on you. The product saved that person's life. It was known that person was heading towards a very significant suicide watch, and the ability to look at you and at the product at their provider and say, I actually slept through the night. Like, I actually had confidence that I could. You give a lot of credit to the Apple Watch platform for being able to accelerate your development and bringing that product to bear. I mean, talk a little bit about the advantage.
Well, so in terms of another benefit of Minnesota is the fantastic people here and their accessibility. And so the team that we have at Night-Ware, if I was in the Valley, they would already be involved in 3 or 4 startups, right? So our CTO is an MIT graduate who built a company over 10 years doing ground guidance for the military in Iraq and Afghanistan, taking satellite imagery and routing people through the mountains of Afghanistan. He took it upon himself to do a full analysis of the 42 watches on the market and decided that for design, for the accuracy of the heart rate monitor, and for the innovation curve, right? So estimates may vary, but my guess would be Apple spent about $500 million in R&D on their watch. For us to replicate what they've come up with in hardware, let alone their software design, ease of use, security, and then of course you look at where Apple is going in terms of the regulatory approvals recently. We really saw the opportunity there. So for instance, the 4 sensors on the back of the watch are all focused on heart rate monitoring and blood monitoring. And so the Apple Watch is actually already capable of doing oximetry, which is a diagnostic for sleep apnea, but they don't expose it in the SDK because there are liability issues. So body temperature, galvanic skin response, there's peripherals. Apple is the place to be because you can get it on Android and there's 17 different versions and it works with this, doesn't work with that. Apple is a design-centric company, and so they've managed all these problems.
Yeah, and I know you're going to be speaking on the mental health platform tonight, so I'm not going to take you away from that one. So I'm going to come back to some of the mental health aspects, but when we're talking about the ability to personalize for a specific disease state, I mean, Paul, clearly OneOme has gotten a lot of press here as a Minnesota-based company, really bringing personalized medicine, not just from, I talked earlier about that Star Trek technology on a Flintstones chassis, but you all are actually doing it, and you're doing it in pharma. Tell us a little bit about how you ended up with the application in pharmacy.
Yeah, so first of all, from an overall global Minnesota perspective, I mean, we deserve a huge shout out, and I recognize not everybody's from Minnesota probably in this room, but just these are three great examples. I'm at awe sitting amongst you guys and hearing the stories that you have and what you've built, and I'm just so proud of being born and raised, so a disclaimer, I'm born and raised Minnesota guy. Got to move around to a couple different states with my career, but when coming back to Minnesota, I happened to spend 11 years down at the Mayo Clinic, and arguably one of the greatest health systems in the world, if not the greatest health system in the world. And Minnesota's full of different health systems and providers that are progressive and innovative and on the leading edge. So you take that, you couple it with the healthcare IT infrastructure that we have based here. When I was starting my career out in the 80s, medical device was mentioned earlier on a panel. Medical device was very proliferant throughout the state of Minnesota and still is, and very strong, but they created a infrastructure of people that understand the healthcare system that not a lot of states have had the privilege to be able to work with. And then you look at the University of Minnesota School of Pharmacy, selfishly from a pharmacogenomic company perspective. Again, arguably probably one of the best in the country, if not the best. I know there was a rating that came out not too long ago that they're on the top. So there is just an infrastructure here of talent that is just really hard to not want to be a part of, first of all, and then to be able to say you're leading a company that has that. So we've had all those different components come together from a Minnesota perspective, and it's made me very proud to lead this company in that space.
And so the aspect of the Minnesota, but taking Minnesota out, genetics, we had color, great conversation with Katie. I've shared, openly, we were early investors in the genomic space. In 2008, that business sold to Medco under the promise of pharmacogenomics, acquired into Express Scripts, and that program was ultimately shuttered under Specialty Pharma. We took a period, of kind of brief break during the Great Recession. But you are uniquely positioned right now with the application of personalized medicine as it relates to pharmacy, as it relates to knowing about how a drug is going to be impacted with my body. Talk a little bit about being at that convergent point. How are you meeting the market?
So first of all, I think it's really important. We get often asked, how are you like 23andMe, or how are you like Ancestry.com? And people wonder, because a lot of the data that comes through organizations similar to that may not be necessarily clinical relevant, but do have a lot of information stored within it. And I think it's really important to discern the difference between clinically relevant data and data that is just very informational and understandable that you can use. So I start out with that premise because pharmacogenomics has been around for a long time. It's nothing new. But the level of science and the level of literature and the level of just understanding of pharmacogenomics is far beyond where it's ever been in its history. And then when you look at when President Obama looked at the precision medicine initiative in his State of the Union address back in 2015, it really started to divide or started to bring forward the need for precision medicine. So we looked at that as a huge opportunity for us. Precision medicine's clearly going to be at the top of mind of everybody. And we've been able to bring all that information with some very, very strong scientific basis out of Rochester to be able to help us build what arguably is very, very complicated. I'm not going to use the word AI because that can be tested and peeled back, but it's in a very complicated algorithm that looks at multi-genes. We look at 27 genes and are able to determine both the metabolomic pathways of those medications. So we've looked at 360 medications thus far. So we decided not to get specific to psychotropic, for example, which some of the pharmacogenomic medication optimization companies have looked at. Because as I started talking to a lot of providers out in the community before I actually even joined the company, because I first had to understand what the need was, they said that many individuals, I think 20+% in the last 30 days of Americans have had 3 or more medications prescribed to them in multi-comorbidities. So you may be addressing one area in psychotropic or in pain management or in whatever, nausea, whatever it might be, but many of those individuals have comorbidities that are not being addressed. So we ended up choosing to go a much more broader, comprehensive route in a very high level of evidence as cost effective as we possibly could be. And I'd like to, if we have time at the end, to talk, Amanda brought up just who is the payers nowadays, or where is the ecosystem of financials, and that's a whole different ballgame.
You can take us there. I think, Liwanag talked about the ability in a nonprofit opportunity that business is a no margin, no mission. There's no margin, no mission across all of yours, right? The efficacy component of what you do, whether venture-backed, strategically sponsored, or that no margin, no mission is very much embedded in each of yours. But I do want to, so we'll come back to that, but Liwanag, I think one of the pieces that's really interesting about your story instead of CaringBridge is that you came from Simon Delivers, which is another manifestation of the convergence, right? That your background being brought to this was a very conscious choice by you and also by the board to bring your background to bear. So tell a little bit about how you came into CaringBridge and then how that's really benefited the business.
Well, I am sometimes told that I'm an example of convergence. So I'm a Jersey girl that has now spent more time in Minnesota. And I came here because I went to law school at the University of Minnesota. Worked as an M&A and attorney, so I was cringing when I heard the term due diligence earlier on the earning panel, just cringing. But I was a lawyer for a while, and then I worked in the grocery world, got recruited to work on digital grocery about 15 years ago, right? And so what I was able to do, and then I worked in an online print business, so I was able to watch what's been going on in digital in the retail space. And what's been great about that is now I have the benefit of seeing how that migration has happened in retail and can apply that into what we're doing now. Of course, we've always been a technology organization, but bringing the best practices of the for-profit world and what's happening in terms of how consumer demands are changing has been a huge benefit for me. And frankly, why CaringBridge? Boy, the opportunity to sort of work for an organization that it's at the arch of healthcare, from diagnosis to when they go home, to when they may be back in the clinical care setting, without regard to the healthcare network, what the health state is. And oh, by the way, we offer a free service, which I probably should have said already. It's free. It's free to the healthcare network. It's free to the user. And it's always been free. So boy, what an opportunity to apply what I've learned in the other industries I've been in to bring that to CaringBridge. Because again, we are an organization that needs to meet the demands of consumers. And that's been a very common theme in my career. You're working on businesses where you need to make sure that you meet them where they're at.
So talk deeper though about the secondary benefit of what your background brought, not only the compression from, say a web to the tsunami of mobile and all platforms, right? That streaming then is I want to be able to access CaringBridge on any media. But then that went from a communication efficiency tool to having secondary benefits. And I think it's important for folks in this room to understand that we've heard a lot about the social isolation. So, it might steal a soundbite, but you bring immediate relevance to that conversation. Right. It's not just a notion of social isolation is a topic that we should be concerned about. You've seen the benefit in your company.
Yes. So the clinical care setting cannot solve that problem without the power of people in a community surrounding the patient and the caregiver. And so the opportunity to harness the power of the humanity that people really have deep within them already it's elicited when someone they care about is sick, why wouldn't you have a service that continues to harness that power to help them on the path to healing? And again, I've used the term healing a few times. There's not a lot of research on the topic of healing, which is different than health outcomes and different than wellness. But what I've discovered in our path to understand, deeply understand healing is people find healing in lots of different ways. It's very unique to the individual. People choose to find healing, and we want to better understand what that means, because we have a hypothesis, and we hear it from our users, that is very connected to health outcomes, and we are on a journey on that. So that is, I mean, talk about the impact that you can create on the world.
Yeah.
When you offer something for free.
And I think that's why I didn't go immediately to the reimbursement, because it was interesting even in the introductory call to make sure that at least people knew who people were as we were preparing. This idea of the concept of healing and that translating to outcomes, which also affects people's willingness to use the platform, is the ability to have a PTSD patient sleep through the night affecting an outcome, the ability to know pharmacogenomic and the right medicine, and the ability to impact a senior who is a dual, who is trying to figure out what system, and comorbid with multiple conditions. So I think this notion of reimbursement is something that we should talk about. And you know, Paul, I know you have a particular point of view, so why don't you lead us into that conversation?
Well, I hope I don't offend anyone, but when I joined OneOme, I was probably a little bit naive, because I really felt like if we had the highest level of science, we created a product with the most well-intended resources that we could bring together and bring technology around it, so its interoperability to health systems, to providers, and to consumers was there. And we focused very much on driving down our costs. So something I failed to say before, as kudos to Minnesota, is the company that our instrumentation that does all of our genotyping is based out of Alexandria, Minnesota. So it's a great Minnesota story altogether. But we chose them for a couple different reasons. One is that they were formerly or they still are, in ag bio, which you have to be extremely high throughput, very low input cost, and then they went over into humans about 5-6 years ago, maybe a little bit longer. And we looked at their technology and realized that this would be our opportunity. This was our moment to defy having to worry about going through millions and millions of dollars of clinical studies and to try to get on payer contracts. And instead, we could come out with a very disruptive, and I know disruptive's a big name, so I don't use that lightly, but we wanted to come out with a disruptive pricing component to our product, which we felt like providers would automatically adopt because of everything else I just talked about. Plus, it's very cost effective. And so not true. We didn't want to have to go to the whole list price, jacking up the list price like every other diagnostic company does. They make it for $100, and their list price to a United or to an Anthem is $4,000, $5,000, $6,000. We just didn't want to have to go there. So the reality is we either have to go there or we have to figure out a different solution. So we're kind of in that evolution right now of can we become more of a technology company? Can we become that medication optimization platform where we're not worried about test by test by test? We think it's important to own the quality of your test, and we do have a CAP-CLIA accredited lab. But we've also had to really, really think hard about how can we go to more of a subscription model and a more inclusive, and work with organizations that are helping people with PTSD and other, oncology type programs, things like that can help patients that are on multiple medications. But to your point earlier, who owns most of the providers today in the space? They're employed by payers. So the ecosystem's getting even tighter and tighter, and they're starting to buy retail pharmacy. It's just becoming one big element that smaller startups have to be able to figure out ahead of time how to deal with them.
Yeah, and so, while looking at Amanda, you can transition. I think it is, and again, doing best with mics, but it is a interesting challenge for you, Amanda, as well, in that you aren't a new startup, but you're facing some of those same reimbursement pressures as well as the same innovation pressures, and you are garnering some attention because you are having success, not only in being able to make money under value, but the outcomes for your patients. what's the future for Genevieve in the sense of this, and how are you dealing with some of the same kind of pressures that Paul in a relative new co is facing?
Yeah, similar. We were able to prove ourselves out in the DSNP space, and we are starting to face the challenge of what's the value proposition for other Medicare products, and I woke up and I was like, oh, it's gonna be easy. Yep, we've been doing it in duals. They have fewer psychosocial support systems in place. More psychosocial issues in place. A long history of disparate economics that play into the Medicaid pieces. Like, the world is ready for us because the market's swirling around for Medicare, and now we're ready to jump in because we have had a lot of success in community and aggregated living spaces around value, full financial risk contracting. This would be great. And I was a little wrong. I think one big thing, and to not offend anybody would be great as well, but one big thing that happened is the cost plan sunsetting and understanding kind of what that means and what kind of impact that meant for the payers. That is a huge flip of their revenue source for them. And so if they're going to turn around and look for the next best person to partner with to help save cost and really improve outcomes and keep their stars ratings high, if they're going to do that, they need to make sure it's the right person. And so I'm jumping through more hoops than I thought to prove that we're the right person, for sure. The best part about Medicare, and one reason I really like it, is, it's a growing system. It's a system that needs solutions, clearly has problems, right? And it needs some of these solutions. And a lot of the stuff coming out of there, it's not all just Part C. I could spend a little bit of time, but I won't, but I could spend a little bit of time on kind of the Center for Innovation and the Independence at Home movement that was had bipartisan support to put home-based medical care back in the home, and I work very closely with a group out of Chicago that's focusing on that. There's a lot of work around basically this country saying, hey, we can't afford everything that's happening, we gotta think in a new way. And traditional Medicare and the way we finance traditional Medicare is not gonna work, so let's rethink it. And we've created a system historically, and especially in Minnesota with the cost products, where we work around the most expensive person, which is the pen, the physician pen, the provider pen. We've worked around this, and we have to reevaluate ourselves. We have to understand, what does the word care management really mean? How are we really going to embrace that? How do we really impact the cost and the quality of this person? How do we really address the fact that clinics close down at 5 o'clock, and the person getting the phone call at 6 o'clock is someone who's going to be on for 24 hours, and they're going to take 300 calls, and they really have never understand how you deal with someone who is chronic conditions, who has polypharmacy, has drug cascading applying to them, and is having a significant event, and we don't have the right person to tackle those things. And so we've really tried to place ourselves at the forefront of the market's changed. We've prepared ourselves in 15 years with this value proposition. Now, what does that mean for us, and how do we partner in new ways? And you ask a little bit about what's our future and what does that look like? And for us, it's partnership, because ownership is a method. It's a method in the state of Minnesota, is to either really fully separate kind of the SNFs and the provider groups, or it's to completely buy everything and the health system owns everything. And I think there's a space in between there for an innovative group to say, hey, put innovation in a separate space, and let's find that epicenter of innovation between the health system, other provider groups, the payer, and the SNFs, right? The skilled nursing facilities, where people live and where health is aggregated. And that could be independent living, that could be senior housing. You could really go upstream from that. So I think there's this epicenter of innovation for where do we live, how do we finance it, how do we provide the right care at the right time, and by the right group that's really funded correctly for that.
Interestingly enough, the behavioral health community is only a short walk away from that on integrating in applications and systems that can affect patient outcomes. But we were early investors also in a behavioral health company that did really amazing things, but it was also interesting to have the bifurcation of we're clinicians who might get paid to get people well, meaning well to be discharged, that after effect and integrated into a clinical system. So we see opportunities for your application to go much beyond, obviously, the nightmare disorders, but integrating in and getting reimbursement. How are you facing those challenges, Grady, and where are you playing out in this?
Well, so Night-Ware is very fortunate in that regard, and I'll touch on that in a moment, but digital therapeutics in general, right? We heard the point about dashboards and interfaces and electronic health record integrations, right? So you have these reams of data. How are we going to utilize that? How are we going to metabolize that in the day of a doctor when they're busy doing so many other things? And so I just attended a digital therapeutics conference out in Boston where companies have raised tens of millions of dollars, over $100 million, and they still have no real story about how they're going to integrate with the providers themselves, exactly how they're going to manage reimbursement. And they're so focused on the regulatory hurdles that they almost can't see past it. And so there was a lot of that focus, right? Because yes, people have context in pharma, they have context in these places, but digital therapeutics is so new, there is no established criteria, there is no precedent really for how to move forward. In the case of Night-Ware, we're focused, so only 60% of nightmare disorder is comorbid with PTSD, but PTSD is where it's covered. And only 20% of PTSD diagnoses in the US are veterans. It's much lower than I would have thought. Now, it tends to be the most severe cases. So in that case, there are 140 VAs across the US. They all have a prosthetics department on site where they're molding prosthetics for the veterans. They're also providing them hearing aids, wheelchairs, any durable medical good, including exoskeletons, right? This is a single payer system that's very focused on, despite the reputation, there are many, many people within the VA that really care about these veterans and are trying to do their best for them. And as long as you have a medical recommendation and a script and you're on GSA contract, the prosthetics departments can make a purchase of up to $10,000 without a central VA contract. And so, fortunately for us, because the VA is currently spending $3 billion a year treating PTSD, and people have the group. I've talked to well over 100 veterans on this. They've tried the evidence-based therapies. They're on multiple drugs. In many cases, they've come off of them and they're white knuckling because that's not what they want. And veterans have a certain ethos, right? They're going to hack it. They're going to get through this. But in this case, where we're just saying, hey, just wear a watch. You're going to be able to get through the night. Your bed partner and your kids are going to be able to get through the night. That's a low enough barrier that they're really embracing it. So in terms of reimbursement, the VA is something of a leviathan in getting where you need to go. But once you're there, there's a very straightforward
He didn't begin
path.
with the trying not to offend, right?
Well, in that they have so many varied disease states they're trying to treat in different age groups. But that being said, there is a very clear path, and the directors of prosthetics that I've spoken to, both on the local level and the national level, they've really been leaning in on this. But there's still a long road to go. In terms of private payers, they are already paying for PTSD. People with PTSD in a private payer network cost the network 5 times more than a normal individual member, than an average member. And so they're already paying, not on the code itself, but on all the other care surrounding that. So they're already paying significant, almost a third of what they pay for apnea in many cases per million people insured. And so that money's already being spent. So whether we look at potential at-risk opportunities to care for these people, maybe in partnership with a larger provider, a larger mental health provider network, we really have more to figure out in terms of the private payers, but it's something to consider in fulfillment. How do you fulfill a digital therapeutic, right? So at Walgreens Clinic, right, there are 370 Walgreens clinics across the country. For $1 a minute, I can have a Walgreens clinician who's trained administer Night-Ware to a patient. So there are opportunities that weren't there 5 years ago. So in terms of convergence, right, what these retailers are doing in terms of providing health care, 16% of all hearing aids are provided through Costco.
Well, and
Right.
and earlier we talked about Bose, right? I mean, again, you're going to start to see some significant, we're already seeing some significant jump the shark kind of opportunities.
Well, and just real briefly, sorry to if I overdid here, but if you look at Nest versus Honeywell, right? Honeywell has a thermostat exactly like the Nest. They just never marketed it as such, right? And so if you look at Nest, right, they purchased DropCam. With the amount of data that they're capturing on people, they could do gait analysis. They could do lifestyle analysis, and they've said as much, that they are looking at that. Our chief medical officer was interviewed by Amazon for a position, right? These people are looking at all different aspects of these disease states, and sleep is so poorly understood. And apnea, you can do a blood oximetry test and you can tell exactly if somebody has apnea at what level, but sleep is not a pulmonary function, it's a cognitive function. But because the diagnostics and the tests and hooking people up to the EEGs, it's so inefficient because you do it for 1 or 2 nights and people don't have the episodes during those nights, therefore you can't get covered and you don't pursue it any further. Maybe you prescribe them something. So there's a real gap within sleep that we see to, of course we want to focus, there's such a specific need here that has a huge impact, but we see many opportunities in becoming potentially the data store for PTSD, as well as around certain types of sleep disturbed categories.
Yeah, and Grady speaks to the convergence opportunity set, and so any one of the three of you, and I'll hand the mic over to you as well, Paul, that, I mean, so Walgreens presents an interesting opportunity. Each of you have spoken to it in again, prep calls, so whichever wants to go first. May I put you on the spot, but as you look at the convergence that's either taking place here in the Twin Cities or at a macro level, I mean, we've heard seniors talk 8 for 80 yesterday. We've had a number of different calls towards that senior community, is drawing a lot of attention your way. What's an area that you're most excited about at a macro level from a convergence perspective? And I'm coming for you, and I'm coming for you as well.
I mean, I think there are a lot of really neat issues. I think there's a Minnesota, and then there's kind of a larger. I think the financing, and I hope I probably hit it home, but the financing of how Minnesota is going to do this work is going to be really interesting. And it's not something that's going to be solved in a year. It's going to take the next couple of years to figure out what all these new Medicare products look like, and who can do the work, and who's actually at risk, and where are we going to be able to do some of this work. Nationally, I think that still exists, but I think nationally we're starting to really say, how do we care for patients in a different way? And and I think Minnesota will be on the leading edge of that, but I think we need to continue to figure out new ways to finance and provide care from tech, from home modifications, from new ways to lower the cost of living and getting old in this country. It is very, very expensive in the last year of life. It is very expensive in some of the settings that I've outlined that we work in. And so as we kind of say, okay, and we have a bit of a culture swing too, where we have, more people caring for people, but, really that generation caring for people in their own homes or bringing them into their homes is how do we care for them, and who is the right person to provide care for that? And so I think there's tech plays. I think those will be answered in really interesting ways. I think there's home modifications, and how do we think about falls? How do we think about pressure ulcers in the home? And then I think from my perspective, the most exciting way is how do we bring medicine, the Doogie Howser medicine in the home, how do we bring that back and make that efficient and make that cost effective and make the outcome something that we can really be proud of, and in doing that, we will lower costs as a nation.
It was interesting on the phone call. It was, I think, prior to Best Buy's announcement, and we've had various conversations in and around the Geek Squad for Aging, right? That, and I know from an investor perspective and in interacting with them in this ecosystem, we've talked a lot about them being very uniquely positioned to be able to take advantage of the technology platforms, the innovation platforms, the Nest versus the Honeywells, and bring that in a packaged way to be able to go at that. So it was interesting to also see that come to play as well. We're going to fight.
I know I am. Well, I was just going to add to that, because really, kind of to Grady's point, like, what is our true core and what is our value proposition? And I think there are all of these things, but what's the future for us and what are the exciting opportunities is to partner in a new way. you know, I think we all got to get to a space, and this town doesn't do that great, so not to offend, but, you know, we have to figure out how we partner and we don't own, how we don't have to, we can do new things in that way, and that will be really neat for this town and nationally of what do we do with all this innovation and how do we deploy it?
I was just going to make a similar point. You know, last night the iconic Marilyn Carlson Nelson talked about the union of forces. And one of the strategic decisions we've made as an organization is we're not going to go try to do something that users have already decided and made a choice about what they want to use, which is why we have a partnership with GoFundMe, because that makes sense. That's where our users are going to try to raise funds for their medical expenses. And so what I'm most excited about is the opportunity to partner with some of you in the room, with other people, and we solve a real problem that we know that you can't solve. So partner with us, and that doesn't have to be a relationship that is about restraint, but about abundance. And I think the other thing I'm excited about is more and more people understanding that we are such a critical component to healing. And I do have to say, I want to thank our investors as well. We are a nonprofit of the people, for the people. We had 100,000 people make a donation to us last year, and some of them I know are in this room. So thank you for your investment, for which I know that you expect a return. So I just want to end with that. That's what I'm excited about, is that people understand that we're a business that also demands of ourselves a return to serve more and more people.
Boy, I think I'm most, just to back up a little bit from an optimism perspective and excited about, you know, we are doing a pilot right now. We're doing 2 different pilots, one with arguably the largest payer in the country and then the second largest payer in the country. And we were out at one of their sites, and specifically in their Medicare population that they treat in a clinic out in Los Angeles. And their pharmacy organization started looking at what group do they have enough FTEs to be able to start working with patients at what level of medications are on. And right now they can only see and spend time with patients that have 12 or more medications that they're on. And they wanted to go down to 8. You know, and when we consider it comorbidity, it's about 5, or polypharmacy, I should say. And so we wanted to work with them and try to figure out a way to get them down to 8, and they were just flat out, we can't. We have to focus on patients that are only 12 or more medications at that time. So I think, you know, the opportunity is there. The excitement is around how do you solve for that, because that's not a small thing to solve for. And I think through the partnerships that you've talked about, through trying to transform from being just specifically diagnostic to more a medication optimization platform, we want to get into all the other disease states, hereditary cancer risk, cholesterol risk, et cetera, similar to what Katie said about color. But right now there's such a huge opportunity just in medication optimization and the amount of waste that occurs. How many people have gone to the doctor or had their friends go to the doctor, and 3, 4, 5 therapies later, they finally start to feel better, or they're so frustrated they just stop going. That happens all the time. Read our stories on our website, and it's just heart-wrenching to see what some of these families have gone through with their children. So I'm excited about making a really big difference in that particular space.
Yeah, it's been interesting to watch the story and the narrative from the conference the first day and a half, and really seeing the implications, the national panel, the national perspective, but you all really having an opportunity that you made some conscious choices about your companies here in the Twin Cities. We've touched on it some, but I do want to put a fine point on that with some of the time that we have remaining, that the ecosystem here in Medical Alley, the innovation that is occurring here is providing leverage. You've spoken to it on manufacturing, on tech, on a variety of different places. But I think we've even seen some cross-pollination. I know even in the panel prep, I sent a news article that was talking about, hey, in California, there's a senior facility that's using pharmacogenomics to help the seniors adhere to drug programs better. And you know, we've got subsets of population in PTSD that could really use the CaringBridge platform to really start to build this opportunity. So even when we talked about convergence, the convergence that occurred even in the panel prep was a really delightful opportunity to see brought out. So as we look to ending our time on the panel together, I really would like to, how can this Minneapolis, Twin Cities, state of Minnesota, Medical Alley really propel you in ways that are differentiating to your companies. And I know, Grady, you've spent some time talking about that in the focus that you've got on some of the partnerships here. But as we close out the panel, really focusing on Minnesota and how the Medical Alley ecosystem can support you, would like each of you to close on that.
Sure. Minnesota is an extremely collegial environment. Through reaching out to Medical Alley, I was put in touch with the person who became my lead investor. He's a veteran, and he had successfully sold a company, and he had a group of investors that believed in him that he was able to bring along, as well as the executive director of the NAVREF nonprofit that is adjacent to the VA, and he was able to help me find our principal investigator for our clinical trial. And beyond that, the community, not just the Medical Alley employees, but the community, there's a lot of folks around who have been there and done that. And they've done it in different contexts, and they have that kind of wry smile of somebody who's, some things have gone well and some things have gone not as well, and they've been able to learn from that. And so a good friend who's at Stella, who's been able to provide us insights, say, how are you going to get that paid for? You know, really challenging us to think through some of those things.
We'll talk about a ripe investment community. I mean, you think about the philanthropic community in Minnesota. We're very proud to be a nonprofit in Minnesota, and we very much get the benefit of many of our supporters being here. But really the number one thing that you can do to help CaringBridge is to tell a friend when they are in need during their health journey. That's the number one thing that you could do to help us, because more and more people who are surrounded by their community who care, that means they are not alone, that they have somebody that they can rely upon for fill in the blank. But that's really the number one thing that we'd ask you to do.
So first of all, after I did say earlier that I've lived in multiple different cities, and I will say Medical Alley, huge shout out to Medical Alley. They have helped in so many different ways with our young company of 3 years. The team, every time, I mean, Frank Jasalki. I mean, who hasn't met Frank and who hasn't been helped by Frank in many different ways in the entire group? So they have helped us connect both with small companies and with large companies. And somebody said it earlier that there are so many great Fortune 100, 500 companies here just in the Minneapolis area. The challenge sometimes you run with them is they're big. They want to be innovative, but they can kill a little company like us really, really fast on one project. But they're starting, I really believe they are starting to understand that as well, and they're starting to either branch off or they're starting to create little groups that are able to work with it. So we've been blessed by being able to work with large companies here in Minneapolis or the Minnesota area, as well as very small startups that are getting more entrepreneurial. And then I spoke to it earlier, the University of Minnesota has been huge champions for us as well, and we've had some great experiences working with them on different projects. So overall, you can't beat the ecosystem here.
Yeah, I would echo all those things. Our tagline is to treat patients like family, and it's really our bar for anything we do, any model that we want to bring forward, any change that we want to make is, you know, what would you do for your loved one, your mom or dad in this situation? And we've been able to build a great little company around it. And one thing that we have gotten to 15 years, and we've done a lot of organic growth. A lot of people, you know, have actually had a mom or dad with us, and then has kind of referred us or has worked with us in a skilled nursing facility, and then taken it to a new one and said, "Oh, you guys should look into Genevive." And it's become kind of a personal point for me to make sure that the expertise that's in this room, the expertise that can be leveraged in this town, they know who Genevive is, and when there's an opportunity, that we come to mind as an opportunity to partner. So I think we are that innovative, nimble organization that is not wholly owned by one system and is outside of that bureaucracy, but is really supported by a community and our owners to really do great work. And I really want to leverage all of the talent that we have and say, when you know something cool is coming down the road, you know you're doing some genetic stuff, call us and see what we can do together. What's the opportunity? And also I would say, I think there is a real space to continue to be innovative in medical practice. I think we still have not really fixed the main problem, and we're working kind of around the system to fix that, and I'm happy to be part of kind of addressing it head on. I think there are other groups that are really doing that I also want to partner with. So for me, it comes down to the great people here.
Awesome. I think as we close out the afternoon, I am grateful for those of you that stayed with us through the opportunity to really look at convergence, not just from I think the sound bites and the excitement that's taking place, the examples, I mean, daily that come out around where this ecosystem nationally is playing. But when we go from a global local perspective and see the opportunities here, not only in the thriving ecosystem that is about our entrepreneurs that are starting new companies, but the attraction of new investors like Ali and others that are coming into the ecosystem, the opportunity for thought leaders to be really, really relevant across our ecosystem. Hopefully, again, seeing the likes of Brian and the Accenture team really bringing a sense of perspective in and around. But then the opportunity for companies that have existed, from newcos and category creating opportunities in digital therapeutics to 21-year-old nonprofits that are meeting their markets, actually solving real, tangible problems that are across our entire ecosystem. We wanted to offer an opportunity for you to see both from an investor perspective, from a newco perspective, and then two CEO voices in between, the opportunity where convergence could really be brought to life. So thank you very much for the afternoon. Again, please consult your program for the opportunities. I know there's the MPR opportunity on mental health is going on, and then this evening, as your program will alert, the Mayo opportunity for some networking and social opportunities this evening as well. So thank you very much. Enjoy the rest of the time.
Thank you, Jodi.